All right, let me give a quick introduction to our wonderful colleague, Dr. Angela Garcia, who has been a member of the Florida Asthma Coalition Steering Committee for many years now, has been a leader in developing pharmacy-focused programming for the coalition, and who is teaching still at the University of South Florida College of Pharmacy. And you can see in the event pamphlet, Dr. Garcia also serves as member at large for Florida Public Health Association and serves on its board of directors, and is active in a number of other service activities for public health in general, health equity, and people with respiratory diseases. So please give a warm Florida Asthma Coalition welcome to Dr. Angela Garcia, who is going to talk to us about monoclonal antibody treatment in asthma.
Thank you, Zan. It's really nice to be a part of the summit this year and to talk about selecting the right biologic. And we have a lot of our attendees who are either in a situation where they're working with a family that may or may not feel comfortable with the biologic, or not necessarily have that confidence in navigating how you decide which one you want to work with your patient or recommend to a patient, or even if one doesn't seem to be as effective, what other alternatives are there based on different demographics for your patient or characteristics of symptomology. So I want to just present this to you guys, and because you'll have access to the slides, you'll be able to also have those as a reference point for you. I'm putting into the chat 2 articles that are a fantastic reference in terms of summarizing content, some of which you'll see in my slides here, but also as something that you can utilize in clinic and reference back to with the other members of your team. So that's available for you guys. So let's get started. So we're going to really kind of work on just a real quick review. So describing how we get to the staging of patients who are really kind of focused on to use our biologics or our monoclonal antibodies, and then kind of look at what are the different options that we do have and why do those differences exist, and then really kind of looking at how the guidelines and best practice recommend you step through how you're going to determine which medication might be the most appropriate for your patient. And then also kind of monitoring and management. How are we making sure that our patients are effectively getting treated? Are there any kicks in the smooth process that we always hope that we have with our patients, but we always experience with some of the insurance issues that unfortunately face us when we get our patients at the pharmacy level. So we can kind of talk a little bit about that. But just kind of as a roadmap, making sure everybody's on the same place, we're just going to do a couple of little review slides, really kind of walk through some of the visuals. So if you're going to take that information and share it with people, you can kind of successfully navigate that. And then again, just reference some of the guidelines and best practice so that you can be the greatest advocate for your patient and really help your team making those selections. So this is an image from a New England Journal of Medicine. And I love this, and I put this up for my students, and everybody kind of has a moment of panic. But when you really kind of look through, there's so many different terms that we're using when we talk about patients with asthma. And so understanding type 2 low, type 2 high, thinking about where these proteins, the cytokines and the interleukins are in our bodies that are parts of this trigger system, and then where these medications, these biologics actually work in the system. And what we know is the higher up, right? The higher up the system that they go, the more effective they are at shutting everything down below them. And so a lot of times we can see certain medications might make it an opportunity for our patients to eliminate other medications. So instead of always thinking of we're adding another medication, sometimes you can ease our families into trusting that if we get somebody and they're responding well on a biologic or a monoclonal antibody, then sometimes we can get rid of some of the other medications. So that burden, that medication burden can be lifted. And what we want is not to feel sick, right? And as a person who grew up with very severe asthma, have had a lot of challenges with that, you almost adopt a sick mentality and you identify as your disease. And so it's really important to help families overcome that by being able to eliminate medication when we can, by helping to identify and personalize the medicine so it's the best medication for that patient, not just necessarily what works. And that puts us in this toe-to-toe conflict with insurance companies quite a bit. And that's why it's really important that everyone on the team, pharmacists, our nurse practitioners, APRNs, PAs, everyone, the physicians, the primary care, other specialty, and then our pulmonology, immunology, allergy specialists, everyone is being an advocate, because the really frustrating thing about treatment is no matter what we decide, the insurance company is going to have kind of that final stamp. And so it's great when we have providers that can do samples, or they might have some medications we can initiate in the office, but that also creates some challenges. And I want to just kind of touch on that towards the end. But we're going to kind of go through. And so this visual will make a whole lot more sense as we navigate each of these different biologics and sort of when we use them and where we use them based on the type of asthma that we're treating. So key terminology, these are those terms that I was kind of mentioning, that it's really important to be familiar, because as we progress with disease state knowledge, we get new terms, we hear different things. And so rather than thinking, I don't know anything about this anymore, it's just sometimes we rephrase things as we start to understand disease states and processes a little bit more. So understanding heterogeneous syndrome, phenotypes, endotypes, those are really things that we're going to hear a lot more. Looking at the immunoglobulin E antibody, so IgE, type 2 inflammation, so we have T2, right? And then we have low and high. Looking at blood and breath biomarkers, and so these are those biologic markers that we use to sort of identify and help to categorize the potential symptomology for patients, because certain things reflect certain systems and how it presents in our bodies. So eosinophils, fractional exhaled nitric oxide, or FeNO, cytokines and interleukins. So those are these very small proteins that are in our bodies that are really kind of targets of where biologic therapy is used. And then TSLP, which is the thymic stromal lipopoietin. And this is one of our new medications, Tezspire, or tezepelumab echo, that is really targeting this. And this is kind of that last one that was kind of up high in the image that we just saw. So just to kind of prep those kind of coming in. So to get us all on the same page, we know that asthma is a syndrome that's characterized by the chronic inflammation of the airways, and also that hyperresponsiveness. So we get the inflammation, we get the mucus buildup, we get the bronchospasms. And so those are sort of these hallmark symptoms that people recognize as asthma. And not everybody presents with those, but those are kind of the hallmarks that we know tend to exist with much higher frequency. The syndrome part of asthma is that we have multiple cells and cellular structures involved in this inflammatory process. It's a cascade that gets activated. And if you think about a waterfall and you see the bottom of the waterfall is all this rough disruption, that's really kind of that expression of all the asthma symptoms. And if you try to just fight it there, you get beat up quite a bit. You get a lot of symptoms, a lot of medications. Then you start dealing with side effects and the costs of these medications. And as you go higher and higher up that cascade, where you shut it off can almost have this downstream effect. And that's where we were kind of talking about earlier. The variations in endotypes are these pathobiologics. So what's going inside the biology of each of our patients, and why personalized medicine is so important. And the phenotypes, which is what we see clinically, really give it that heterogeneous syndrome, right? So it doesn't look the same, and it can be very different among patients that are in the same family. So siblings, parents, And so just simply putting all of the family on the same medication is not the solution. It is an obstructive airway, which means our patients can, most of the time, they can breathe in fine, but that air that gets in there gets trapped. And that's the problem of the trapping. So then when they're breathing out or exhaling, they're not exhaling fully. So then they have this additional pressure that remains, and then they're breathing in against that pressure. And so if we can start targeting where these things are happening with our medications and do a better job of matching up the right medication based on what the patient needs, we can decrease medications, and we can certainly decrease side effects. And that's something that's really important for me. So we kind of talked about those hallmark symptoms: inflammation, breathlessness, chest tightness or pressure, and then cough, especially at night and early morning. Those nocturnal awakenings tell us quite a bit about the level of severity with our patients, and gives us clues to other areas of the kind of the four corner pillars that we really focus on with the management of asthma, and can be a target for indoor triggers. And that's part of something that's such an important piece. And with our groups that are doing home visits, certainly those are the areas that we lend into those conversations. Now, when we look at these endotypes and phenotypes, we see these type 2 asthma or these non-type 2, and some of them look more like that allergic versus non-allergic asthma. Some have to do with the frequency of childhood onset versus adult onset. And this isn't an end-all be-all. It's just to kind of help look at where are we at. A lot of the children, the majority of children have the allergic onset of asthma as children, and that's less as you become an adult, but it doesn't exclude any of our patients. And so we always want to come in with a completely open blank slate, do a great job at histories, and really kind of navigate with our patients to find the best and most appropriate treatment that gives them the greatest quality of life. So we know that the US EPR3, now we have EPR4, and the guidelines for GINA have created some conflict. We heard earlier today, and there was a great question: why doesn't, if the GINA has these guidelines and we have providers that are trying to follow GINA guidelines instead of our US standard guidelines, it creates a problem, and these medications don't get paid for in the pharmacy. And so the idea of trying to do something good for our patients and follow some of the guidelines or the recommendations ends up with our patients having no inhalers at all, because what's written doesn't get paid for, it doesn't get adjudicated or processed because the insurance denies it. And then instead of having something available for our patients, we have nothing. And so it's really important that providers understand the limitations of being able to write according to new guidelines and recommendations when there's those discrepancies between what is approved with the FDA and therefore what would be covered under insurance. The other issue, and a lot of people are not aware of this, I spent 10 years in community pharmacy, and this was a frustration on our end. We want to get medications to our patients, but the insurance company blocks them. And 1 month they'll pay for something, and the next month they'll change. And they can actually change the formulary every single month. We usually don't see it change except for like either on the quarter or at least halfway through the year. And it really depends on the buying and how many inhalers are filled. And the insurance company looks at what they're making and what they're losing. And so they'll make adjustments. And so that's where we see our patients having to flip between all these different inhalers when we find something that works great, and then all of a sudden we can't access it. And that's where really working with your team to get these insurance overrides and to challenge the insurance company to say, this is where the patient is stabilized at. They did not respond to previous therapies. Please don't change this, and get a permission and an override in order to keep our patients on the same medications if those patients are responding. There's a lot of overlap between the Global Initiative for Asthma, or GINA, and our expert panel report. And what's important is to remember that the largest proportion of change happened in what we would classify as our mild persistent asthmatics. So we were having patients that were not staged with severity appropriately. And so then people were kind of confused and putting different medications on board with our patients. And so those were causing concerns and challenges with managing our patients. We know that it's a high prevalence disease, and it's disproportionately represented in minority populations. And about 10% of the 30 million patients who do have asthma have severe asthma. And when we see that they're uncontrolled despite the appropriate drug, appropriate technique, appropriate adherence, then we're left with how else do we help them control this disease and have a quality of life that's not overwhelming. And when we look at the costs for asthma, severe asthma is about 50% of all the costs that we have when we're dealing with asthma episodes, issues, medications, hospitalizations, emergency department visits. So we know this small group is responsible for half of the cost of the disease that we face in this country. And that's where really that focus of having treatment for severe asthmatics is extremely important. So when we are staging our patients, right? So the first thing that we want to do is to stage patients based on their severity. So when we see patients, most of the time, we're not actually seeing patients for the very first time who've never been assessed for asthma. We're working with patients who've not been successfully treated. So it's very difficult for us to understand where the patient really truly is in their baseline of severity, and we don't pull meds off to see how bad it gets, right? That's not what we do with our patients. But when we're talking about biologics, we're looking at these patients that are in this severe persistent asthma, and it can be moderate persistent if it's still really challenging for the patients and they're not responding. And so we're really in a place where we're trying to determine that they have failed the efficacy of medium dose and high dose inhaled corticosteroids. And we're determining the necessity of biologics. And sometimes patients still have to stay on those inhalers, and we get them on the biologic. And when they get stabilized on the biologic, then sometimes that inhaler can go off the patient's regimen, or sometimes we can go from a high dose to a medium, or from a medium then down to a low dose steroid, which all of those things are great. But when we then continue to visit with our patients and have those follow-up management appointments, we're really not going back to how severe is it. We've already determined the severity. That is their baseline diagnosis. And now we're looking at symptoms of control. So is our patient well controlled? Are they not well controlled, or are they very poorly controlled? And we have to make sure that in assessing for control, our patients have the appropriate technique, they are adherent, and we have identified the triggers that could be eliminated both indoor and outdoor. And this includes referrals for immunocap or other immunologic testing, so that we get a real clear picture of what is triggering our patient and what things can we eliminate in the environment. What might we be able to eliminate in food, how we might be able to optimize care and other comorbidities, and then what we're left with, right? And so in those patients who, despite those three things, right? So I tell my students things that'll help them remember, right? AT&T, make that call. You check adherence, you check technique, and you check triggers before you disrupt the treatment. Because if those things are the problem, we don't want to keep stepping our patients up and exposing them to more medications or additional therapies, because we know the cost burden. We also know just the burden of taking so many medications in itself, right? Health literacy issues are there, access to care, appropriate diagnosis and appropriate management. And the more meds you have on board, the greater the challenges are for that. So These patients, we've made that call, AT&T is in check. They're still not well controlled, and they're very poorly controlled, meaning highly symptomatic, experiencing a lot more challenges, and many of them unfortunately have to do a lot more of the oral corticosteroid, not just the inhaled. And these are those patients that we're really thankful that we have the biologic options for. Now, in our updated guidelines, we can see this intermittent asthma still as a PRN short-acting beta agonist. In the GINA guidelines, that is different. When we look at the persistent asthma, right? So we have mild, moderate, and then severe. And our mild is step 2 treatment, which is our daily low-dose inhaled corticosteroid and an as-needed short-acting beta agonist, or using the inhaled corticosteroid and the short-acting agonist concomitantly, meaning we use it when we need it, right? And that's really more in line with the GINA guidelines, but we really have to remember that for our patients on the inhaled corticosteroid side, there is a certain number of inhalations per device. And if our patient is using those beyond what is the, right now in the US, approved number of doses, these patients will lose their medication. They'll run out too soon. And then some insurance companies will not provide another inhaler. The short-acting beta agonists, they have 180, 200 puffs. So that's not the issue there, but it's really on the corticosteroid side. When we get to moderate persistent asthma, this is our step 3 and 4. And I tell my students, step 3 is 3 syllables, moderate is 3 syllables. So this is where we're really dealing with that moderate persistent asthma. And this is where we're seeing the daily and PRN use of this low dose ICS and formoterol. Now, formoterol is a long-acting beta agonist, and this was that whole point of coming in saying we're used to seeing these short-acting beta agonists, but now we have this long-acting beta agonist being used as a rescue. And the reason that formoterol is able to be used is because it is, although it's a long-acting beta agonist, it has a very fast onset. That's what we need the short-acting beta agonists for, is they're a very fast onset, but unfortunately their efficacy weans or fades away sooner. So that's where we get that shortness, right? So formoterol is the only long-acting beta agonist that we have currently in the US that's approved to be used in that capacity of immediate onset, but long-acting. And so that's where it serves as both the rescue and the maintenance as part of that SMART therapy. The 2 drugs that we have that are in this combination are Symbicort and Dulera. So again, as our providers are trying to follow guidelines and recommendations, that's what we're looking at here. But unfortunately, the approvals for those meds to be used in this manner is mismatched. And so that's a very important conversation to have with your team to make sure that everyone is aware of and how to successfully navigate based on the patient's insurance. When we get to step 5, 5 looks like an S, and that's our severe patients. And so this is our severe persistent, step 5 and step 6. GINA has 5 steps. The US guidelines have 6, but there's a few differences in those, but overall they're very similar. And that's why it's really important to know the difference of GINA guidelines don't typically match up with the FDA approval of drugs. And so therefore using guidelines that are not US-based guidelines tends to lead to some issues with insurance paying for medications or creating rejections. When we look at our patients, typically those that are severe, so they're either using medium to high dose inhaled corticosteroids plus the long-acting beta agonist, and then plus or minus a long-acting muscarinic antagonist. And we're hearing and seeing that the LAMA, or the long-acting muscarinic antagonist, may not have the same level of efficacy in certain populations, predominantly African American. So additional studies are going to come out and look at that. And that's similar to drugs that we use in hypertension. So there's some genetic differences. There's some etiologic differences. And so some medications may or may not be best and may or may not be first line. And those are things that we need to be adherent to and diligent to the medical literature so that we're ready and we're prepared for the patients that we're serving. Now, our patients that have the oral systemic glucocorticoids, some might be frequent pulse dosing, and some might be just consistent daily dosing. When these patients are not responsive, or there's still such a significant burden from the disease itself, this is really where we want to consider using the biologics, right? And so our different biologics really have different areas that they're targeting for their mechanism of action, or the mechanism by which this drug is going to work in the body. And so we really kind of have four main areas, plus the TSLP, which is one of our newest biologics that came out on the market earlier this year. So one of the things that we do is we really try to look at, are we able to reduce damage to the lungs? Are we able to reduce symptomology? Are we able to reduce morbidity and mortality? And that is truly our goal in treatment, because we want our patients to have the best quality of life they can with the fewest medications and the fewest number of complications. And sometimes those things match up beautifully, and other times they are a definite challenge to navigate. So the fractional exhaled nitric oxide is really associated with eosinophilic airway inflammation. And so typically when we use pulmonary function testing and spirometry, we're looking at those, but they're difficult to perform, especially in the young and the elderly, but also when you have complications breathing, it is almost impossible to do a great performance there. And a lot of our pediatric pulmonologists have this Vioxx handheld sort of desktop device, and it's got an active component for children and adults. I personally like the child one because you get to blow a balloon, or somebody's moving across this little cavern, and that's how you get that exhalation, or the exhaled breath, to push, 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 until we're able to measure that. And we're looking at that inflammation and can use those devices to say, are the patients responding to their inhaled glucocorticoid or inhaled corticosteroid? And when the higher that is, the better the response is. And so some patients, will have a better response. Same with our biologics. Some biologics work better when this pheno level, this biomarker, is higher. Some, it doesn't matter if it's higher or lower, and others we look more at the eosinophil count as kind of the target where it works. Again, talking about the cytokines and the interleukins, those are these little small proteins that are either involved in the growth and activity of immune cells, which are part of that immunologic response, and really kind of that underlying part of inflammation, or the interleukins that communicate between the cells, right? So when you have interleukins, they are sort of recruiting, right? These are the inviters. These are the people who are charging things up, right? They're kind of your cheerleaders. They are getting everyone excited. And we really want to keep these interleukins under control, because they just kick in all of these additional cellular structures that really present with the challenges of control and increase our symptoms in our patients. Now, these T2 high, right, asthma targets, this is really kind of moving into that personalized medicine. But what's great about asthma is if you take somebody's blood, you can see the types of blood cells that are in that sample. And based on what's in there from a histopathologic kind of arena, if you see mast cells, we have mast cell stabilizers. If you have high leukotrienes, we have leukotriene modifiers. So depending on what the cells are that show up, you kind of have some gauge as to where you might want to start with the baseline of treatment that's going to be the most effective. And unfortunately, we don't have all of our patients experiencing that level of care, and that would be great. But that's really one of the fun things about being in asthma, is knowing your own challenges, but being able to help build up and personalize the approach to the patients in the care of the clinic that you're in. So we know that about half of the patients that are diagnosed with asthma have this T2 driven inflammation. So this in severe asthma, it's a higher prevalence. And we know that biologics are very effective in those patients where we have this T2 high, right, or these higher expressed cytokines and interleukins. And so one of the newest drugs that came on board, Tezspire or tezepelumab, this kind of addresses a different protein, the TSLP, right? And that's a precursor. So if we can knock that out or block that from signaling, then you don't activate everything else that's below it. And so it's very exciting to see where Tezspire is going to fit in terms of our recommendations for patients because of its ability not to be limited by certain biomarkers and ages. So we have our antigen, it expresses in the dendritic cell, and if we're following the T2 response or that highly allergic response, we see that there's certain interleukins that are really involved in this T2 response or T2 high asthma response. And so those are the interleukin 4s and 13s, interleukin 5, 3, 9. And so those are really the ones where we see and a lot of association with eosinophils. We have IgE, which is a different kind of biologic that focuses on a kind of a unique population. And our mast cells and basophils are all kind of involved, but the eosinophils become very important. So our interleukins, our eosinophils, these are all kind of markers that we have a focus on. These are in mediators of inflammation, and these kick in the other things, the histamine, the leukotrienes, prostaglandins, different enzymes. And so again, we are activating this huge group of inflammatory processes. And then that's where we get this hyperresponsiveness that leads to our asthma symptoms. And so those are the things that are really important, because if we can get in front of these instead of chasing them, we have much better outcomes. Now, we know that 70% of the patients have an allergic component and would be very responsive to monoclonal antibodies or biologics. And so in that T2 and high and T2 low, we have to distinguish the difference of those. And those kind of lend another level of decision-making when we're selecting the biologic. The expressed cytokines, in particular, IL-4, IL-5, and 5-RA, IL-4A or 4R, and then IL-13. These are when we have type 2 asthma, we really see a high expression of these. So then we kind of, again, get another layer of information that helps guide us down that decision-making path. Now, when we have the patients with this T2 high asthma, aeroallergens or things that we breathe in, whether it's indoor or outdoor triggers, they activate TSLP, which then begins to trigger some of the other interleukins, right? So TSLP, interleukin 25 and 33, those are all those ones that are the first round of activation. And then they have subsequent activation in IL-4, 5, and 13. We know that they draw in and activate the eosinophils, the mast cells. They can segregate and pull in the IgE. And so you can kind of see then why we have this whole disruption and why those high level proteins and areas are really kind of a great focus. Now, this slide is really kind of there to point out, again, just for you to say, okay, where are we at with our patients? Up here is our TSLP, our interleukins 25 and 33, whether the patients have an allergen-based or a non-allergen-based expression. But when we look at the allergen-based, we see our TSLP is here. We go to the T2. From T2, they activate mast cells, which then kick in our IgE. These T2 also will go in and activate interleukin 13, which changes some of our cellular structures, and goblet cells are activated as well as those eosinophils. If they're activating interleukins 4 and 13, we get to beta cells, which then trigger back into once they meet with T cells are activated, we start releasing the IgE antibodies. And then with IL-5 or interleukin 5, we activate the eosinophils. All of these things end up triggering smooth muscle cell activation or constriction, and that's where we're getting some of that bronchoconstriction. And then they also increase the deposition of mucus, right? So we know that these things are activated. And what we do know is that there's markers, right? So these serum markers are markers from the blood that we take from our patients that give us kind of a heads up of what might be going on, and then guides us in the direction of appropriate treatment and therapy. So we're looking at blood eosinophil counts, our serum IgE, their FeNO scores, serum periostin, and then we look at those things, because then we can say, will this or will this not be a good candidate then for biologics? We know that T2 low asthma is really triggered more by neutrophil or mixed polygranulocytic asthma. And so that's kind of a whole different class, but we're seeing some biologics that are being developed to target that. Now, most biologics are not appropriate for patients who are non-allergic, but we see that they're appropriate because that's where they started to test. And they will continue to test in different populations to broaden their approval for use in other patients. But for now, really our patients that are highly expressed allergic type patients are the ones that are our primary focus. We see that there's new therapeutic drugs that are already being studied, trying to come out with, again, with GlaxoSmithKline, with AstraZeneca. But we really, I'm excited about the TSLP because it's really got a unique opportunity, because it's not restricted by a certain biomarker. And then if there's some resistance to glucocorticoids, TSLP can kind of sometimes override those resistances and give us some successes with our patients. Now, with the biologics, we have seen that these are being demonstrated for safety in younger and younger patients, and these are not new drugs. They have been around for a very long time. We are just using them in different ways. And so it's exciting that we're using these with children and adults with asthma, because we know that they have been there in rheumatoid and inflammatory diseases from that way, from dermatologic issues, so eczemas, those sorts of things. And we tend to see these overlap in our patients, asthma and eczema, right, and allergies. So if we know they've been very effective there, then rather than adding a whole nother drug on, sometimes these patients are going to get a little bit of benefit. The dosing is similar for some and different, but for the most part, we're really looking at these biologics to target some pretty significant markers for us. And so we have reducing the annualized asthma exacerbation rate, right? We want to reduce the number of times they have these exacerbations, because anything over 2 is an extreme concern for us. We want to decrease emergency department visits and hospitalizations. Wanda was talking about that and how profound those numbers are. And we want to constantly use these as markers for our success in how we manage patients, how we educate them, how we elevate their ability for self-management. Oftentimes the biologics allow us to reduce the need for high dose steroids. We may still have to have our patients on the inhaled corticosteroids, but they're not at high doses, which is a really good thing. And for those who are oral corticosteroid or OCS dependent, sometimes we can get them off of that and then begin to taper down that steroid, which again, all of those things are good because of the side effects that come from those. Improving control, improving lung function, and improving quality of life. Those are all key markers for us. And so we really are excited about that. Now, just a quick review of those, right? We have Xolair or omalizumab, and this is really kind of one branch of the group that's really focused on the IgE, right? So we're not really looking at FeNO, we're not really looking at eosinophils, we're really looking at IgE markers. And so during COVID, we ended up with the self-injection, right? So it's one of the few that is a self-injection option. Otherwise, all patients go to the pulmonologist's office. It's very rare to have these in the primary care, but mostly in the pulmonologist or allergist, immunologist offices. They would typically go there for their appointments. Now these patients can administer from home, and it's important that they know how to use these devices and that they're comfortable with that. For interleukin-5, that's really kind of the survival of the eosinophils, right? So we want to, if we have a high level of eosinophils circulating, not only systemically, but also concentrated in the lung, this is where sink air or resolizumab and Nucala, which is mepolizumab, these are kind of our go-tos here, and typically more on the adult side, right? Xolair is for use in peds and in adults. Sinqair and Nucala, they've got some restrictions, but really this is kind of, again, our eosinophil, high eosinophil kind of medication. And Nucala also had a reformulation of a device so that patients could do that from home. Fasenra is another one. These are when we induce eosinophil apoptosis, or we kill those eosinophils, right? They have our bodies will make them, right? When we are using Fasenra, and it's amazing how quickly Fasenra kicks in for our patients. Not only do we deplete it in the lung, but we start seeing the peripheral depletion. So a systemic level of inflammation caused by the eosinophils begins to lower. It binds to the interleukin-5, prevents the recruitment and activation, right? So it's got a lot going on for the benefit of using Fasenra. And really it's best if a patient has had 3 or more exacerbations in the previous year, if they have nasal polyposis, and if they're less than 65% of their predicted pre-bronchodilator FEVs. And so literally within 24 hours of administration, it depletes what's in the lung and a near depletion of what's circulating in the blood. And so really, this is a fast onset, and within a week, your patients can actually feel differently. How frequently you have to use these also makes kind of a difference in some of our patients in terms of adherence and wanting to have this. Now, our IL-4 receptor alpha, or IL-4A, this is where our proteins, the interleukin-4 and 13s, really regulate and drive that T2 inflammation. And so if these are really your markers, Dupixent or dupilumab really is kind of the target for that. So we're looking at kids over 12, anyone over the age of 12 and up, that have that type 2 inflammation with increased eosinophils and increased FeNO. And they may be dependent on oral corticosteroids or not, but this is really kind of a drug that we might select then. And we have some really great responses. Now, TSLP as the target protein, and Tezspire, which is our tezepelumab, this is really the one that has gotten a lot of excitement. And so it is beginning to get more inclusive in the literature, but this is the most recent one. And so you'll start to see more of that showing up. Now, these next few tables are really sort of to help summarize information. All of the references at the bottom are where the information has come from, and kind of summarizing these to make it easier to navigate. So this one here really just talks about your agent, your brand name, to help the age indicator, where it's acting, and sort of what its biggest criteria is. And then your dosing, right? So some we see with Fasenra especially, it's every 2 months. And that's what makes it quite attractive. The criteria, again, is those biomarkers, whether it's interleukins, IgE, eosinophils, or exacerbations. These are really kind of what we want. Now, we do have black box warnings on Xolair or omalizumab and Dupixent, which is dupilumab, but the black box warnings came from when the drug first came out. Since then, they have demonstrated that there's really no difference in fatality, mortality, any sort of major difference in the safety profile, but it's very difficult once you get a black box warning to get rid of that. And so it's really great that we have the opportunity to be able to put this information for you guys, so you can kind of see, is your patient greater than 6, great, you have a lot more options. If your patient is not, and they're 12 or 13, you have some different options. And then if they're 18, that's when you have something different. right? So sink air is really the one that's limited to adults, older adults. Everything else is either 12 or 6. But again, this chart is there for you to reference when helping to make that. So I've made some modifications to this from its original presentation in the literature, just to kind of help walk through. So we have our basic biologic therapy, right? And we want to say, is this person appropriate? So the first question is, what's their age? If they're 6 to 11, we've got 2 options. And if they're greater than 12, we have others. So if they're anywhere between 6 and 11, we look at omalizumab and mepolizumab, and we determine based on what the biomarkers are, what their symptoms are, where we want to go with our selection. And I've got another table for you guys for that. If they happen to be greater than 12, we want to know from that point, are they on oral corticosteroids, or are they taking it orally by tablet? Yes or no. If no, we go straight over to omalizumab, and we go there and we see how that's effective. Now, we want to use biologics for at least 4 months to determine their efficacy before we switch, before we stop. If they are on an oral corticosteroid, then we're looking next at their eosinophilia, and their eosinophilia is their eosinophil rate. And we see the different options there. And so, you know, now that we've got kind of a flow diagram, you can kind of see where we break for certain medications and where we might be as a means to support selection. Now we see these agents and kind of lung function, right? So this really kind of is summarizing how effectively it reduced asthma exacerbation rates and where we are with lung function. And then if they were on oral corticosteroids, were we able to wean or reduce those based on the different drug, right? And so we see that Tezspire, we could also decrease the inhaled corticosteroid right away, same with Xolair. And it's not that the other biologics don't do that, but that wasn't one of their primary points in the study. So we see more information coming out, and they do they mirror each other quite similarly. But again, we want to see 4 months of treatment on a biologic before we determine that it's not efficacious or it's not working. Again, we want to make sure that our patients, we've made that call, right? AT&T, if they're adherent, if they're using their technique, and if they're controlling those triggers. And then we start looking at those biologic markers. We want to see, as a profession, getting in front of the costs of the inhaled corticosteroids. The fact that we have inhalers that are $300 and up is just an atrocious thing. And as a pharmacist, it angers me because there's no reason for it to cost that much, because it doesn't cost that much. And we see that in other countries, and I do mission work, so I know when I buy medications that I'm taking out of the country and I'm ordering from different areas, it doesn't cost this. And so we've got to do a great job of advocating to change that. We want to use the guidelines, we want to reference those, but we have to be aware of the limitations of implementing them as they're stated in the guidelines until things catch up and our patients can afford those. And we also want to look at monitoring for control. Right? We're not trying to rechange whether they're moderate, persistent, severe persistent, mild persistent. They have their diagnosis, we're working with them. And if their patient has not been to a pulmonologist, they need to go. If they haven't, and that should be an annual to a biannual at the most, they need to have their allergies tested at least every 3 to 4 years. If you have a very symptomatic patient, every 2 years, and even annually, depending on what's going on with your patient. We want to make sure that we're utilizing tools. We're using shared decision-making. You're educating your patient. These are your options. These are your choices. Here's this information. Here's this. What would you like to do? If your patient surrenders and says, I don't know, you pick, then that's the patient giving you the trust to know which ones to select for your patients and how to be judicious in the fewest medications that are necessary. And then again, being really on top of our triggers. So we want to confirm the diagnosis. We want to do the AT&T, and then we want to look at any coexisting syndromes, right? So those are kind of the steps. Then we need to know what their blood eosinophil count is, their pheno, and if we have spirometry, that's exceptionally beneficial. And then we need to know whether or not they have oral corticosteroids daily. If they are without daily oral corticosteroids, and we start here with their blood eosinophils, they're less than 150 to 1500 cells per microliter, or greater than 1500, we start to navigate down these flow diagrams into whether we get into an anti-IgE or our Xolair, or anti-TSLP, which would be Tezspire. And so you can see, do they have a perennial allergy? So do they have high allergies? These respond great to, pheno that's elevated or that's lower. These respond really great to pheno that's elevated. So we have Xolair, we have basically everything. If they have perennial allergies and they have high eosinophils, anything is going to be effective for those patients. It's just finding out which one is the most effective. And then we have those that don't have allergies but high pheno, and where we're at with the selection of those medications. And again, same thing. You look at the eosinophil count, you look at other biomarkers and coexisting, and you kind of see where we're going. Most patients, again, if they're between this lower and higher rates, anything that's on the board is going to be effective for these patients. It's just then adding each of those other criteria and determination, especially with insurance provisions. And then those that are extremely high, we look at the interleukin 5s. And so those are really things that are important for us in the management of our patients and in terms of kind of navigating. Now, specialists don't have to do this tight navigation, but it's certainly something that we then come back and look at good responses and poor responses. The same exists for those without or with an oral corticosteroid, where we go, how we recommend it, and then assessing for response. This is a patient characteristic and a recommendation. So again, each of these are kind of the characteristics, and then whether this would be a specific criteria under each of the different classes. And so the IL-5s include this grouping, the TSLP, our 4RA, and then our IgEs. And so again, hoping that this serves as a reference for you. We do have challenges, right? We have those challenges, and I want to make sure that there's an opportunity for questions, but this is really an important slide, because if our patients are not adjudicating an inhaler in the pharmacy, they have to have a minimum of 3 months consistently for the insurance to then pay for the biologic. And so if you're having those challenges, making sure that samples, they can be given, but we still need the patients to get them there. And if it's a cost issue, then that's where advocacy becomes really big. And again, I can't stress.
To move to the next presentation now to keep ourselves on schedule, but I would still encourage folks to use the event chat to ask questions.
And I'll stay in and watch that. So,
excellent. We may have a little
thank you guys so much.
Well, so think about those questions, get them in the event chat, and we'll follow along. We are going to get ready for our next speakers, and thank you, Dr. Garcia. That was a terrific presentation. Slides are available on the summit agenda. Our